All right, guys, it's 4:04 on the first Monday of February 2022. So it's time for another NASCI Curious Cases webinar. Thank you so much for joining. I see we have a good number of attendance today, and I already got a text of more people joining us. Hopefully, they'll be able to do so. As usual, this is a relaxed environment. Everybody's welcome to show their cases and participate in the conversations. So, whatever you guys want to talk about, or if you have cases you want to share with the group, please do let me know. I do have a few cases prepared as well, so we can start whichever way you guys want. So if any of you have cases, shall we? Anybody wants to start the webinar today? First of all,
I'm just
oh,
nice case, and so by the time you're done, I'll probably have one case to show.
all right. Thank you, Prachi. I was about to ask if you guys could hear me, so because you can, so that's great. All right, so I'll start with a couple cases, and we'll go to Prachi and anybody else. I think Dr. Kiska was going to join us. Dr. Young, I think, was trying to join us as well. So we should have a few cases. Let me stop this animation and show my screen. Share. All right, so you guys can see my screen properly? All right, fantastic. So I just prepared a couple of cases that kind of straightforward, but I thought they had good teaching points. So the first one says case 2, but it's case 1. So the first teaching point is review your slides before you present them. History here is a CT of the chest to rule out PE. So anybody wants to comment on this image? It says just one axial slice through the lower part of the heart. Any takers? Anything that's different or? All right. So anybody wants to tell me what is this structure here that I'm pointing? Do you see my cursor? Do you see this structure? What is it?
No. Enlarged coronary sinus.
Yeah, that's the coronary and looks a little bit plumper than usual, a little bit larger than usual. So what would your differential be for if you just notice as you're scrolling and you see that an enlarged coronary sinus? What would you be thinking of usually? What
Persistent left-sided SVC.
Yeah, that's a great thought. Anything else?
Anomaly of the pulmonary veins. Association with the anomaly of return pulmonary veins.
Like a PVR to the coronary sinus or to a left-sided SVC present? Okay. I actually have seen that once. Anything else? And I think you're on the right track because you're thinking shunting. What could increase volumes through the coronary sinus, right? That's your train of thought. Anything that could increase shunting through the coronary sinus. All right, somebody brought something here on the chat box here. Coronary artery fistula, fair enough. Yes, a fistula to the coronary veins, so a venous system, arteriovenous fistula. That could do that. All right. All right, let's look at this. So 3 coronal reconstructions through the heart, moving from, I guess on the left is the most anterior, moving towards the back. Anything there that catches your attention? And again, this is a P study. This is a poor bolus timing for sure, but it's not gated, so that's why you have those slight artifacts, slab artifacts on the heart. This is a case from 2006. Dr. Phil Young was my medical student in the reading room that day. I was a fellow. You remember the case, Phil?
No. I probably should, but I don't.
I don't know if you were. I don't know if you were in the reading room that day, but it's from around that time. I'm sorry. There you go.
So I'm not entirely sure, Jacopo, but is there in the third image some kind of communication between the coronary sinus and the LA that you're trying to show there, or is that just averaging here?
No, correct. And you can see it also in the middle image right here. There's a communication between the coronary sinus and the left atrium. So that's a partial unroofed coronary sinus. It's a partially unroofed. You can have unroofing of the entire sinus, and I have a slide on that classification. But yes, it's better seen on the middle image here, and also here on the one on the right. So it's a case of unroofed coronary sinus. Again, it was a nice pickup on the axial films on the person reading the case that day, and just felt the coronary sinus was way too large for normal physiology, and started looking a lot more closely. Did some recons, which are always useful, and I think probably we're way more used to recons nowadays than we were back in 06, but that's what this turned out to be. So very quickly, unroofed coronary sinuses are it's a type of ASZ in an essence. So because that's hemodynamically, that's what it acts and presents like. It's the right to left shunt at the level. So that's where the atrial wall between the sinus and the left atrium is partially or completely absent, like we said. And it can be associated with a persistent left-sided SVC and some heterotaxy syndromes for sure. But I mean, anything can be associated with heterotaxy syndromes, to be honest with you. But it has been shown to have an association with left-sided SVC. There's a classification for them. Puts them in 4 types, and of course nobody needs to remember this because they're not that common to start with, so you don't have to memorize this. But type 1 is just a completely unroofed sinus with a persistent left-sided SVC. Type 2 is a completely unroofed sinus without a persistent LSVC. Type 3 partially unroofed at the mid portion, and type 4 partially unroofed at the terminal portion, which kind of looks like the one that I showed you, towards the terminal portion right before it entered into the right atrium. So this would be a type 4 unroofed coronary sinus that we just saw. Any questions about those images? Anybody, you want to see them again, or we're good? All right. Here I have a chest CT, and I don't remember what it was done. It's also an older case, but I thought it was a great case to show. So I have 2 slices through the middle of the chest. Any comments? Any observations?
I see a low density in the left atrium. Maybe I'm overcalling it, but it doesn't seem to be the kind of low density you usually see from streak from the spine. Is that the finding?
So if you thought that was a finding, Dr. Kishka, what would you do about it?
I would order the most expensive test available, like an MRI.
All right.
No, no, I don't know. No, I think for something like that, honestly, this is honestly what I would do. First thing I would do is produce a thicker section MPR image. So if I'm looking at something like a 0.6 or 1 millimeter cut, I would actually make a 5 millimeter cut, because for large objects that have just a very small variation in Hounsfield unit attenuation, you make a thick slab and you can more confidently know that you're seeing a finding. So that would be the first thing I would do. And if it persists, then I would probably recommend either, a contrast enhanced exam with, triggering off the left atrium. If there was some reason they thought this person had a mass or a thrombus, or there was some echo out there, then I would proceed to a cardiac MRI.
All right, so we did something similar, but probably a little bit easier. We just windowed the thing differently, made the windows a lot narrower, and this is what it looked like. And we kind of convinced ourselves that there was a mass there, kind of straddling by the mitral valve orifice. So we kind of got a little bit very self-confident here and questioned if there was a mass there. The patient ended up going to echo. So before I go to echo, any of the residents out there or students, any differential here for what we're seeing? Or what we think we're seeing?
So it could be it could be a left atrial myxoma. I guess that would be the number one that would come to my mind.
Very good.
If it were truly a mass left atrium.
That was the first thing on our mind as well. Patient doesn't have a history of neoplasm or anything to start thinking on other sorts of metastatic lesions. So we were thinking, of course, myxoma as our number one possibility here, based also, on the size and the patient having no symptoms as far as we knew, reading the chest, the chest CT. So you see echo on this patient. Hopefully the movies are looking nice for you. So yeah, this was a large myxoma. It's interesting that it looks larger on the CT, and I wonder if it's related to motion, artifact. We're kind of catching it in both positions within the atrium, and as it goes, into the ventricle, so where it just looks like it's much longer than it really is when you look at it. And here's another view here, and you can see same concept. It just looks significantly larger on CT. Although on this view, it does look pretty large on echo for sure. So this turned out to be a myxoma.
Do you also have MR images for this one, or just with the echo?
I'm sorry. What was the question?
Do you also have MRI images for that one, or did the workup end with the echo?
It ended up with echo. There was no need for an MRI in this case. People felt very confident that it was a myxoma and it was surgically removed back then. So most common primary tumor in the heart is going to be the myxoma. Most commonly in the third to sixth decade of life. Size, as you can see here, can be very, very variable, up to 15 centimeters, if not larger, in some rare cases that have been published for sure. This one was sizable, but did not get to that size, of course. Most of them left atrium. They usually have a relation to the fossa ovalis or a pedicle towards the fossa ovalis. The second most likely position is going to be the right atrium, and they're very rare, but you can see them in the ventricles as well. But again, those are going to be very few and far in between. They're usually sporadic, although there is a complex, which is called Carney's complex, which is a triad of younger patients with myxomas that can be in atypical locations and with a predisposition for recurrence. Third case, this is a composite of images, but let's look at the first one. So who wants to describe the sequence and what we're looking at?
Well,
Go for it, man.
okay.
You want? I mean,
I don't want to, if somebody else wants to chime in, they should. Is there anybody else wants to take a try? All right. Well, I'm always willing to embarrass myself. So I think we're looking at late gadolinium sequence here. And the interesting thing is that you have abnormally thick myocardium along the septum, normal thickness along the lateral wall. You have areas of enhancement in the areas where it is abnormally thick, and it's it doesn't have a subendocardial distribution, at least. Now the odd thing is you've got this area that is extremely low signal intensity, and I am wondering, it's hard to know what that is, but I'm wondering if what you are, I hope I'm going down the right road here, that if what you're looking at is some sort of, calcification can have that appearance. It could be just that you're looking at some portion of myocardium that's not enhancing. I don't know if this person had something like hypertrophic cardiomyopathy and had a procedure, like an alcohol ablation or something like that, that would cause no gadolinium to get in, similar to just because of microvascular damage. But those would be my thoughts. I think we're looking at a hypertrophic cardiomyopathy patient who had some sort of septal ablation. That's my guess.
and that, sir, is why you are the president of the North American Society for Cardiovascular Imaging.
Oh, okay.
No, good job,
thank you.
Brad. No, that was very nicely done. So you picked up on all of the findings. So there's a hypertrophic cardiomyopathy, somewhat asymmetric, and then there's that area of abnormal late enhancement in the anteroseptal segments toward the base, with clear microvascular obstruction centrally there. And it has this, it's a very funny distribution. It's not what we see with the infarcts, like you said. It's a very characteristic distribution. this patient here is the patient when going to therapy. You can see here the catheter angiography of the left main, and I know you can see my cursor. So this here being the LAD. And why do we know this is the LAD? So a trick for you guys when you look at these cases to know this is the LAD, it's the one that's going to have the branches that are pointing toward the patient's feet. So you see this one here, that's a septal perforator. This one here is a septal perforator here as well. So when you have that vessel and you're not sure which vessel you're looking at on this left main injection, the one with the branches pointing straight down towards the feet, that's gonna be your septal perforator branches. So that's gonna be your LAD. So this patient had his left main injection, then it was selectively catheterized. You can see here a selective small wire going into the first septal perforator, and you can see here the markers proximally of a small balloon that was inflated. And here you can see through that little catheter, you see the balloon is inflated, and an injection of contrast mixed with alcohol. So you can see the vessels and the septal perforator and its small branches in the septum as we were giving the patient virtually a small heart attack. So these are done under anesthesia because they are terribly painful. Patients actually having a heart attack by design. So it's a septal alcohol ablation to treat obstructive pathophysiology related to hypertrophic cardiomyopathy. Again, just a quick review, about 2/3 of patients with hypertrophic cardiomyopathy will have a significant gradient across the LVOT, and that's what we call obstructive physiology or pathophysiology, and that's what differentiates an HCM from an HOCM, the obstruction at the LVOT. The main treatment continues to be medical, so inotropic drugs like beta blockers or calcium channel antagonists. Having said that, for patients that remain symptomatic after medical therapy has failed, they will need either a surgical septal myectomy to open up that LVOT or an alcohol septal ablation. So again, this is in the minority of patients that those that fail medical therapy. A couple of historical notes here that are interesting. So Brugada, the cardiologist who described the Brugada heart rhythm as well, he's the first one to use alcohol into the septal branches of the LAD to treat refractory VT. After that, Sigwart and Kuhn both reported reduction of systolic wall motion in HOCM patients by temporary balloon occlusion of the coronary artery. And it was Sigwart the one who actually introduced and described and defined what we now know as septal alcohol ablation by introducing these small infarcts via alcohol and through a small catheter into the septal perforator branches. And this is an alternative to surgical myectomy. Complications are very rare now. Nowadays, the 30-day mortality is really minimal, less than 1%, and very rare to have a cardiac event in these patients as well. And when there is a complication, the most common complication is that these areas of infarct become substrate for new arrhythmia, so patients end up with having a permanent pacemaker after the therapy. And again, this is a rare event that they need this. The reduction of the gradient is observed immediately when you do surgical myectomy as expected, and I have heard historical comments, from surgeons that the patient wakes up after the procedure and just feels completely relieved of the symptoms from the obstructive physiology there after the surgery. Now, the benefits of alcohol septal ablation are not going to be immediate, of course. They're going to be delayed as there's going to be some remodeling that has to happen to that segment of the heart, and they usually take at least 6 months after the procedure. As it states here, the heart will undergo a process of remodeling, but not just that segment of the LV, that anteroseptal segment, but the entire heart starts to remodeling, and there's data to support that there's going to be a reduction of size and thickness of the other segments in the heart. Clearly, if there's no gradient, but no pressure again, so there's going to be some deconditioning of the rest of the LV, but also there's going to be improvement of hemodynamic improvements also in the left atrium. There are two large meta-analyses of the gradients, LVOT gradient between alcohol septal ablation and myectomy, and they have shown that there's no significant differences in the New York Heart Association functional class, peak oxygen consumption, and exercise capacity at late follow-up. So they have been to be deemed equal in outcome for these patients. I think for the most part, though, still the practice, at least here in the U.S., continues to be favoring us septal myectomy. So the surgical procedure seems to be more commonly used than alcohol ablation. May have to do because the improvement is immediate. I don't know if anybody knows about that or why. We'll look. And I just wanted to add a case. So this is the same patient pre and post myectomy. You can see the image on the left. You can see how thick that anteroseptal segment is, and you can see that turbulent flow at the LVOT. There's a lot of artifact there related to high velocities. And then on the right, you can see how they kind of carved that muscle out right here, and it opened up, and there's actually no turbulent flow, at least on these SFP images on this patient. So again, guys, and your Greg, Prachi, Phil, anybody on the call, so in your sites, are you seeing a lot of alcohol ablations or mostly myectomies? I mean, when we see images in our practice, I usually see myectomies. I can't recall when's the last time I saw a septal ablation case.
I feel like I haven't seen a septal ablation case in a couple of years, actually. I feel like the histories usually come through with myomectomy. We actually see a lot of hypertrophic cardiomyopathy, but I don't know how often they're getting. I just don't see very many alcohol ablations come through. I haven't seen one in years.
Dr. Kirsch, this is Kuba at University of Iowa. I'm actually sitting with one of the cardiology fellows, and she was saying that here at Iowa, we do predominantly alcohol ablations and very few myomectomies.
Okay. No, and it probably has to do quite a bit with the expertise of your surgeons versus your interventional cardiologist, and the level of comfort at each institution based on that. Very good. Thank you for sharing that. Anybody else? All right.
I can show it.
Fantastic. I'm gonna make you presenter, Prachi. 1 second. You're just gonna have to accept the invite. You should see it now.
Yeah.
Perfect. All right.
Okay, so I hope you can all see my screen now.
Yes, we can.
And this is a case that I want to share with you because I really found this challenging. So I'll tell you what the patient came in for. That part was very easy to answer. And the question was is there some retrocrural adenopathy, which is what was questioned on our spine MR. But this really was, as you can see, very low density. And it was just a cyst on a chyli. You can see it track all the way up. But interestingly, there were some other findings. So you can see regarding the aortic knob, you can see it's a right aortic arch. You have an aberrant left subclavian artery, and you have a diverticulum, which would indicate a left-sided duct. So this is a complete vascular ring. Now, just curious what everybody thinks about the pulmonary arteries and the anatomy of the pulmonary artery, and then I'll show you the lungs, which I thought were the other interesting part of this case. So here we are looking at the right and left pulmonary arteries, and let me think if you see anything that's unusual or something that we don't routinely see, and this is regarding the orientation and the way the pulmonary arteries arise. So any thoughts about this?
Can you?
Hi, Prachi.
I'm sorry. Go ahead. Greg.
Oh, sorry. This is Aus. Yeah. Hey, how are you? Yeah. Is it a crisscross pulmonary artery?
So why do you say it's crisscross, Aus?
Well, so looks like there's a kink.
It is crisscross pulmonary arteries, which is exactly what I was showing. But it would be great if you can kind of talk about why you said crisscross pulmonary arteries for the benefit of everyone else.
Yeah, exactly. So just the orientation of the branching and the branching pattern of the pulmonary arteries. We should see the both pulmonary arteries at the same level. Like the bifurcation should be at the same level, but here it's different. So we see first the left pulmonary artery and then the right pulmonary artery after that.
Okay,
You know,
so one point is that the left pulmonary artery has a superior takeoff compared to the right. Typically, when we see PA bifurcations, you see them come off together. Okay, that's one.
Prachi,
The other thing,
what I was looking at
yeah, sorry.
that caught my attention, I was thinking crisscross, and I think we presented a crisscross case a while ago. If you stay at that image, go back, there seems to be a kink
Yeah.
at the origin of the right, and we saw that
Uh-huh.
as well. So if you go there, it's right there. That's
Yeah,
kinking.
so
A few cases I've seen.
very, yeah, yeah, excellent, Jacobo. So the big thing is when you look at crisscross, and it can be sometimes hard to see on the axial images, but if you look at the right pulmonary artery, you will see that it is more contiguous with the leftward aspect of the PAs. It seems to arise from the leftward aspect of the PA. And if you look at the left, it seems to arise from the rightward aspect. And if you can conceptualize it in your head now, you can see that the PAs are crossing over each other and they have this superior inferior orientation. So here it is, and you can look at it again, see how the right seems to come off the leftward aspect of the PA. So here is the main PA, this is the right, and this is really coming off the leftward aspect of the PA. And if you compare the left, it's coming off the rightward aspect. And it becomes very obvious when you're looking at volume rendered images. So crisscross PAs can have a fairly significant association with other congenital heart diseases. By themselves, they don't really cause too much. But we've seen a little kid where actually there was crisscross PAs, the patient had bronchomalacia, and they had to undergo, it was actually a little kid, so they did a 3D splint based off the CT data set, and they used that splint for treating the bronchomalacia. Now, if you look at the lungs, and I'm curious to see if anybody has any ideas, I thought this was a very interesting and kind of intriguing case. So middle-aged person was in the 40s or something, and if you look at this doesn't look like emphysema, has very central perihilar, these kind of cystic changes. And I'm curious to see what if you have any ideas, but like I said, it doesn't look like emphysema, and the question was, could it be some kind of an early insult, very early in life? So maybe some BPD related or some kind of infection that happened early in life that led to these kind of changes. But it was just an interesting constellation of findings in a person who was coming in for a question of retrocrural adenopathy, which turned out to be just a dilated cisterna chyli, but then also had these vascular ring in the form of right arch with aberrant left subclavian artery, crisscross PAs, and these very interesting looking lungs. So I'll just take a break here. If anybody wants to or has any other thoughts about this case, would love to hear.
And so the two areas that will be part of the mid-year incentive plan.
Prachi, is there vasculature from those hyperlucent areas that is tracking back to the atria?
The pulmonary veins were all draining appropriately, and these were just centrilobular. But yeah,
So is it actually
are the veins? Yes.
You mentioned the word cystic. Do you actually think it's a little hard for me to tell?
Yeah.
Are they actually cysts, or are they just I can't tell, but you think you said they are actually cysts?
I don't think these are emphysematous blebs or emphysematous changes. This distribution would be highly unusual for this.
Right.
So it doesn't look like emphysema. It does look like cystic changes, but it's a very unusual appearance and does not fit in with the usual cystic lung diseases.
I guess what I mean is, like, if you were able to put your finger in the middle of that, do you think you'd be touching the lung, or it would just be in air?
So you're thinking air trapping.
Sorry.
Great. So you're thinking that if those are areas of air trapping, that's your question? Like,
or just that's like it's abnormal lung parenchyma as opposed to a cyst. I just can't tell.
It's hard to. I see what you're saying. So you're thinking like a bronchial atresia type.
Yeah, something like that. Yeah.
Well, it's definitely not bronchial atresia because there is.
Yeah.
But like a sequestration, like, I know it's not the right spot, but sometimes you get those
not the right spot, and it doesn't have any kind of aberrant supply, so
yeah,
doesn't fit with that. I think it is some kind of destroyed lung parenchyma, and that's why I was thinking, is it like an old bronchopulmonary dysplasia? And we were trying to get a history of this patient was prematurely born or something. So it is some kind of an early insult to the lungs, I think.
Mhm.
And something that happened very early in life. And that's why there's a bunch of these cardiovascular abnormalities and these very interesting looking lungs. But yeah, this was more like something to show the group and see what people thought about it. It's not like I have an answer to this case.
Yeah, Prachi, I agree with you. I was thinking about either BPD or CPAM. However, I'm not sure if it looks like a CPAM.
Not a CPAM. Yeah, I totally agree.
Yeah, yeah. But yeah, I agree with you. So this is the two things that came into my mind. Good case.
All right, this was the case I just wanted to share with everyone.
That's a great case.
A great case. All right. Thank you, Prachi. Anybody else has cases that they want to share?
I have a case I could show. I have a case.
All right, let me. You should get an invite.
All right, can you see this?
Yes.
Anyone see it? All right, so 55-year-old female seen for evaluation and treatment of recurrent pericardial effusion in the setting of seronegative RA. She has known coronary disease with several angios, most recently in 2019 with patent stents. Since 2018, has had recurrent pericardial effusions. In February 2019, she had a pericardiocentesis and catheter drainage. It recurred in April of 2019, had a window and biopsy performed, which is negative. At that time, she was evaluated for intrapericardial vascular mass, which was seen on coronary angiography and a coronary CT. So here's the angio where they injected a right coronary. You can see this mass here. So we did a CT on her as well, and this is the outside CT from 2019, where you see there and this kind of pericardial fluid. And so we did a repeat CT for comparison. The way we did it was a coronary CT with an immediate dual energy delay to kind of give it time to get more of a perfusion look here. And you certainly see that there is, here's kind of a color map showing a blood volume map here, clearly showing there's fairly intense and peripheral predominant enhancement of this lesion. Looks a lot like the angio. And you can see that it's increased in size since 2019. Any thoughts?
Bill, is this a long expected location of the RCA? I mean, I know you showed that the angio, or the conventional angio, but I couldn't tell, was it just getting supplied by it, or is it along the expected course of the RCA?
So it's not. It's actually like a SA nodal branch coming off back here. There was kind of a wussy little RCA over here. It was a left dominant system, and there was a sinoatrial nodal branch coming back here that supplied this thing here.
Because I've seen, like pseudoaneurysms of the coronaries that will slowly enlarge, but usually that's, well, at least the case that I have seen is come right off of the, off of main coronary artery, not some small branch.
Sure.
Could it be an angiosarcoma?
Okay, angiosarcoma, we did entertain that differential. The only issue is that it's growing pretty slowly for an angiosarcoma, and presenting a little bit, 2 years. So, and, usually angiosarcomas are just more, they're not so smooth and well-defined. They just tend to be more evil looking.
Mm-hmm. That pericardial effusion looks high attenuation, is it?
they reported the outside, it was kind of serous sanguineous, you know. It didn't have a high hematocrit or anything like that. The cytology was negative. The tissue that was sent from the outside was negative.
Could it be a paraganglioma?
So that was my thought. I thought, hey, I think this is a paraganglioma. So I suggested that they do a dotatate PET CT. And this is just another comparison here. In retrospect, it had been present on the prior coronary angios if you go back to 2015, slowly growing. And again, I just think angiosarcoma wouldn't present like that, right?
Correct.
So I said, why don't we do a dotatate PET CT? Because I think it's a paraganglioma. And does anyone here read nukes? Well, it's positive. So I said, oh man, this is a paraganglioma, you know, next case, right? And they went to surgery, and it was a benign hemangioma. And apparently, some of them can have enough lymphocyte activity in a hemangioma that you can get dotatate activity, which wasn't well described, but apparently is. I've had 2 cases now like this that we've seen that they look hypervascular. And of course, if you go back, you know, it's peripheral nodular discontinuous enhancement that follows blood pool, right? And we kind of, if you put this in the liver, nobody would blink and say, oh yeah, that's hemangioma. It's amazing to me, like you put it there and all of a sudden we're all kind of throwing up our hands and suggesting more advanced imaging. And in this case, what they think is that the recurrent effusions have nothing to do with it, that they're just from her rheumatoid arthritis. You see, she's also got a pleural effusion over here. And it was just an incidental finding unrelated to her clinical presentation at all. Kind of interesting, huh? Just for comparison, here's an actual right atrial angiosarcoma, and you can see how much more evil this looks. It's kind of infiltrative and aggressive, and you see how much we did it early in the delay phase and how much this enhances here. And you can actually see tumors studying throughout the pericardial space, right? And you can see visceral and parietal pericardium, this kind of slightly irregular nodular enhancement. And here's one that actually presented with a frank rupture of the right atrial angiosarcoma. What happened was this person had a recurrent effusion, was taken to do an echo-guided pericardiocentesis, and then kind of crumped on the table. They got an echo, a transthoracic echo, and saw that there was this free-flowing blood back and forth across the right atrium. I said, oh my God, I think either we like with the needle like lacerated the right atrium or a coronary artery. And the patient actually stabilized pretty quickly with the drain plate, so they sent over to CT to get a better anatomic definition. And you know, I said, well, I think this is really just an angiosarcoma here that is ruptured. And the reason that the patient didn't just die on the table is because of all this tumor study throughout the pericardial space. It's kind of frozen it and prevented tamponade. But anyway, kind of interesting case. Any comments or thoughts?
Those are
really
unbelievable
cool.
images.
That's insane.
Yeah.
All right. No, great.
As a follow-up, what happened with this patient?
The patient didn't live very long. It's not a treatable condition, right? She got chemo. Actually, they went in, the surgeon patched this up and essentially just put like a giant patch and said it was all this tumor here was so friable you couldn't really sew to it. So it put this really wide patch across it, healed somewhat. The patient went on some sort of palliative chemo regimen, and then actually I think donated tissue for a sarcoma research program we have here.
Thanks for sharing, Phil. That's a pretty insane couple of cases, both the hemangioma, dotatate avid, and the angiosarcoma. Any comments or questions, guys? Anybody else have cases to share? All right. Well, if that's it, then I want to thank you all for joining us for another webinar. I think we had some interesting cases here for sure. Not mine, but the ones from Prachi and from Phil. So thank you guys for coming and sharing. And again, we'll see you guys the first Monday of every month at 4 p.m. Eastern Standard Time. Bring cases. Don't be shy. Just we'll take any case. They're always interesting. There's always something we can talk about. Really appreciate you guys. Have a fantastic rest of the day.
Yeah, awesome. Thank you very much. Great cases.
Thank you.
Thanks.